Welcome everyone to the fourth webinar of the Science of Aging Series 2021, a joint webinar series brought to you by Inside Scientific and the American Physiological Society. For this series, we've lined up a number of webinars, all focused on the science of aging being conducted by leading researchers around the world in their relevant fields. This is Sarah McFarlane from Inside Scientific, and I'm very pleased to be your host for today's event. Today's webinar is titled Aging and Bone Health, and will feature Dr. Joy Wu, an associate professor of medicine at Stanford University. In her presentation, Joy will discuss the pathophysiology of bone loss with aging and some therapeutic approaches. Before we get started, we would just like to acknowledge our partners at the APS and the Alliance for Aging Research, and also to thank the sponsors for this webinar series for making it all possible. So, without any further delay, I'm very pleased to welcome Dr. Joy Wu to the floor. Joy, take it away whenever you're ready.
Thank you, Sarah, for that introduction. It's really a pleasure to be here today to speak about aging and bone health. So the skeleton is really a remarkable organ. I think we're all familiar with the functions shown here, providing mechanical support, protection for internal organs, serving as a storage depot for minerals like calcium and phosphate. What's less appreciated is that the skeleton is also an active endocrine organ, for example, secreting FGF23 to regulate phosphate homeostasis, and that the cells that form bone, or osteoblasts, and their precursors play a critical role in the support of blood cell production or hematopoiesis within the marrow. The most common disease affecting the skeleton is osteoporosis, a disease with a very high clinical burden. Half of all women and a quarter of men over the age of 50 can be expected to have a fracture that results from the bone loss in osteoporosis. These fractures can be devastating. There are approximately 300,000 hip fractures a year in the United States affecting adults, and the one-year mortality after hip fracture is greater than 20%. The costs associated with osteoporosis-related fragility fractures is now more than $20 billion a year. To put osteoporosis in perspective, shown here are the lifetime risks at age 50. In women, this risk far exceeds the risk of breast cancer, whereas in men, the lifetime risk of fracture is similar to that of prostate cancer. Fracture risk is dependent in part upon bone mineral density, and shown here is the bone mineral density across the lifespan. So as children during growth and adolescence during puberty, bone mineral density gradually increases with accrual of bone mass, and peak bone mass typically occurs in the 20s. After that, there's a few decades of stable bone density, and then a gradual decline with age. In women, there's a period of more rapid bone loss associated with the menopausal transition. Men have higher bone mineral density than women, and so fracture at lower rates, but as I showed earlier, can still experience osteoporotic fractures. Because of this decline in bone density with age, the prevalence of osteopenia, which is an intermediate risk of bone loss, and osteoporosis increases dramatically with age. Shown here in the 50s, only about 5% of adults have osteoporosis, but already 40% are at risk for low bone mass. And by the time adults reach 80 or over, more than 25% will have osteoporosis. Bone mineral density is measured by dual energy X-ray absorptiometry, so-called DEXA scan, most typically measured at the lumbar spine and the hip, where we look at the femoral neck and total hip. Bone density reports out a T-score, which is a standard deviation of a patient's measured bone density compared to a reference young adult population, matched for gender and ideally race and ethnicity. The World Health Organization classifies bone density as normal if the T-score is above -1.0, as osteopenia for T-scores between -1 and -2.5, and osteoporosis for T-scores lower than -2.5. For older adults, we expect T-scores to be negative, meaning lower than the average say 30-year-old young adult, but sometimes you wonder whether the bone mineral density is out of proportion for age, and that's where a Z-score comes in handy. A Z-score is a standard deviation of a patient's measured bone density to their age-matched population, and when the Z-score is particularly low, it is useful as a notice to look for secondary causes. Now, bone mineral density is one important factor in determining fracture risk, but equally important is the effect of age. So shown here, I've used the WHO's Fracture Risk Assessment Tool, or FRAX, to calculate the estimated risk of a hip fracture in the next 10 years for a woman of a given height and weight at ages increasing from 55 to 80. Across the x-axis on the bottom, from left to right, is a declining T-score, as reported from the DEXA scan. The arrow in the middle points to a T-score of minus 2.5. That's the WHO's threshold for a diagnosis of osteoporosis. The dashed line is the 3% estimated 10-year risk of hip fracture, which is a threshold at which we recommend pharmacologic treatment for osteoporosis be considered. You can see, looking first at a 65-year-old woman, whose curve is in blue, that she crosses the 3% threshold right at about a T-score of minus 2.5. So right at the WHO diagnosis threshold for osteoporosis. Younger age can be protective. So if you look at the curve for a 55-year-old woman in gray, you can see that she does not cross the 3% threshold until her T-score is almost minus 2.8. In contrast, fracture risk rises sharply with age. So if you now look at the 80-year-old woman in dark green, she will reach the threshold recommended for treatment at a T-score of only minus 1.2. Fragility fractures can occur in a number of different bones. Most common are vertebral fractures in the spine, followed by wrist and hip fractures. But the patterns of fracture differ by age. In the lower left of the right-hand panel, you can see that forearm or wrist fractures are most common in the youngest women in their 50s. In contrast, right above that, hip fractures rise substantially with age and are most commonly seen above the age of 70 or 75. Spine and humerus or upper arm fractures also occur, but those are more evenly distributed among age groups. To understand how we might intervene to treat osteoporosis, we need to understand a little about the underlying bone physiology. So shown here, we have on the right in light blue osteoblasts, which are of mesenchymal origin. These are the bone-forming cells. Once they've formed bone, they can become quiescent on the surface as lining cells, ready to reactivate should the need arise. Or they can become embedded in the mineralized matrix as new osteocytes. Their action of bone formation is opposed by the work of osteoclasts, shown to the left in green. These are cells that resorb or break down bone using both a combination of acid and secreted enzymes. And they're of hematopoietic origin, derived from the monocyte macrophage lineage. The two processes of bone formation and resorption are closely coupled. You wouldn't want either of them to occur unopposed. So again, osteoblasts are from mesenchymal stem cells, and they secrete factors like rank ligand that stimulate the differentiation of osteoclasts from hematopoietic precursors. The osteoclasts themselves, in resorbing bone, likely release factors from the extracellular matrix that in turn can feed back and regulate osteoblast recruitment and maturation. The bone loss that occurs with aging is due to a variety of factors. One is hormonal, declining estrogen levels, particularly in women, but also in men. With age, there is a decrease in the number of mesenchymal stem cells as well as their osteogenic potential. Inflammation increases with age and contributes to bone loss, as does cellular senescence. And sarcopenia, a topic that has been addressed in other seminars within this Science of Aging series, is also an area in which there's growing awareness of the importance of muscle and bone crosstalk, contributing to bone strength and quality. To give you one example, cellular senescence is one factor that increases with age. Oxidative or genotoxic or other stresses can induce cells to enter a state of cell cycle arrest, secrete senescence-associated factors. Joshua Farr and Sandeep Khosa's groups have shown that senescent cells, shown here expressing markers including P16-INK4A, P21, and P53, are accumulating in the bones of older mice at 24 months of age as compared to younger mice at 6 months of age. And these senescent cells can be found at higher levels in osteoprogenitors, osteoblasts, and osteocytes, but also in cells of the immune lineages, B cells, T cells, and myeloid cells. Senescent cells represent an appealing therapeutic target for the treatment of osteoporosis, and indeed, in a genetic model of inducible senescent cell clearance using a synthetic ligand, a decline in senescent cells expressing GFP is accompanied by an increase in bone mass, shown on the right, with micro CT images of both the spine and the femur. Work on pharmacologic treatments has identified dasatinib, a tyrosine kinase inhibitor, and quercetin, a flavanol, as potential senolytic treatments. And in aging mice treated with these two agents, again, there's a decrease in senescent cells, shown here by senescence-associated beta-gal expression, and again accompanied by increasing bone mass, measured by micro-CT in both the spine and the femur. In my osteoporosis clinic, I tell patients that we have two general approaches to the treatment of osteoporosis, to the restoration of bone mass. One is to block bone breakdown, and this is by far the most common treatment approach. Most prescriptions for osteoporosis are written for either bisphosphonates or denosumab. But ultimately, to cure osteoporosis, we will need to promote bone formation. And we currently, in the US, have 3 FDA-approved medications that are anabolic: Teriparatide, abaloparatide, and romosozumab. In our lab, we have been very interested in the actions of teriparatide and abaloparatide, which are both agonists for the parathyroid hormone receptor. The PTH receptor is a 7-transmembrane G protein coupled receptor. It signals through a variety of G proteins. On the left, one common mediator is the G stimulatory protein that increases protein kinase A activity. On the right, the GQ pathway leads to activation of protein kinase C. Both parathyroid hormone, PTH, and parathyroid hormone-related peptide, or PTHrP, are ligands for the PTH receptor. Teriparatide is the first 34 amino acids of parathyroid hormone, PTH, whereas the more recently approved abaloparatide is a synthetic analog of parathyroid hormone-related peptide. Teriparatide was the first to be approved as an anabolic treatment for osteoporosis now more than 15 years ago. This is one of the pivotal clinical trials showing that once daily PTH administration substantially increases bone mineral density at both the spine and the hip in the femoral neck, and that this is associated with a significant reduction in fractures over time. Now, my lab has been very interested in what I call the complexities of PTH receptor signaling, despite the fact that teriparatide has been in use now for almost 2 decades. There are still many things we don't understand about PTH receptor signaling. For instance, there are different effects depending on whether it's administered intermittently versus continuously. The anabolic effect of PTH wanes over time. PTH has different effects when used in combination with anti-resorptives, bisphosphonates versus denosumab, and we don't fully understand why. There are some differences. Although PTH and PTHrP are both ligands for the PTH receptor, there are some differences in the downstream signaling cascades that are induced. There's some very interesting crosstalk with Wnt signaling, which is another regulator of bone mass. And finally, there are some limitations that make these medications less popular for patients. There's a boxed warning for abaloparatide for the risk of osteosarcoma, and both medications require daily self-injections. Just to highlight some of these questions that remain, PTH has different effects on bone mass depending on whether it's given continuously or intermittently. As a model of continuous PTH, the disease primary hyperparathyroidism associated with constantly elevated PTH levels, this PTH increases both osteoblast and osteoclast activity, but preferentially stimulates osteoclasts, leading to increase in bone resorption and a net decrease in bone mass. In contrast, when PTH is given once a day, as it is with teriparatide, again, both osteoblasts and osteoclasts are stimulated, but osteoblasts are preferentially activated, leading to an increase in bone formation and a net increase in bone mass. And at the molecular level, we're still working to understand these differences. Another interesting question relating to PTH is why the anabolic effect both plateaus and wanes. So shown here is a clinical trial administering teriparatide initially over 2 years, 24 months. And you can see that the anabolic effect, this is as measured by percent change in spine bone density, is greatest in the first 12 months as compared to the second 12 months. And importantly, when teriparatide is stopped, there's a very rapid loss in bone mass that can be reversed by readministration of teriparatide. This has clinical implications. Shown in the right in red, patients who receive teriparatide or PTH only and then transition to placebo lose much of the bone that was initially gained on PTH. In contrast, if these patients shown in blue are transitioned to a bisphosphonate or alendronate, they can maintain the gains in bone mineral density. Another interesting phenomenon in bone mass regulation is that you might think that the combination of an anabolic therapy with simultaneous anti-resorptive might yield greater increases in bone mass than either alone. A somewhat surprising finding was that in patients treated with teriparatide with a bisphosphonate, in this case oral alendronate, the combination shown in green is in fact worse than the effects of PTH alone, suggesting that in some way alendronate blunts the full anabolic effect of PTH. In contrast, when PTH or teriparatide is combined with denosumab, which is an anti-resorptive medication with a different mechanism of action, it's a monoclonal antibody targeting RINE ligand, which regulates the terminal differentiation of osteoclasts. The combination of teriparatide and denosumab, shown in green, appears to be better than either agent alone. And again, the molecular mechanisms underlying these phenomena are still not fully understood. I mentioned that abaloparatide is a newer FDA-approved treatment for osteoporosis, and that abaloparatide is a synthetic analog of PTH-related peptide. In a head-to-head clinical trial shown on the right, there are hints that abaloparatide may be even more effective in decreasing fractures than teriparatide. Both PTH and PTHrP are ligands for the PTH receptor, but they have very different kinetics. Shown here on the left, in the upper panels are the interactions between PTH and PTH receptor, whereas the lower panels show interactions between PTHrP and PTH receptor. And all you need to know is that when the ligand is bound to the receptor, the fluorescence turns yellow. And I think you can see that PTH remains associated with the PTH receptor for a much longer duration than PTHrP, despite the fact that both ligands are being washed out at the same time. In the lower panel is the tracing for cyclic AMP, and you can see that PTH in black induces a sustained change in cyclic AMP levels, whereas PTHrP in red induces only a transient increase in cyclic AMP levels. On the right is a schematic, and studies have shown that this is due in part because PTH can remain associated with PTH receptor even after internalization and continue signaling in endosomes, leading to continued cyclic AMP production. In contrast, PTH-related peptide appears to interact with PTH receptor only at the cell surface, leading to a much more transient or shorter acting signal. And whether this translates into those differences that we see between teriparatide and abaloparatide in vivo in respect to effects on bone mass is a very interesting question. So to get at some of these questions, my lab has been using mouse models to study PTH receptor signaling. We have both mice lacking PTH receptor itself or the downstream G-stimulatory alpha subunit, or GS-alpha, deleted in osteoprogenitors, which are cells early in the osteoblast lineage expressing osterix, a transcription factor. We've shown that mice lacking GS-alpha in osteoprogenitors have severe osteoporosis. On the right, in the upper panels, are skeletal preparations of the rib cage from a control wild-type littermate and from a knockout littermate at 1 day of age. And you can see that almost every single rib in the knockout mouse has been fractured by the process of delivery. In the lower histology panels, at 1 week of age in the proximal tibia, in a wild-type mouse, you can see abundant pink spicules of trabecular bone. In contrast, in the knockout mouse, trabecular bone is almost completely absent. The outer shell of cortical bone is also significantly decreased in these mice. And we've shown that this is due to a failure of bone formation rather than an excess of bone resorption. We've also shown that mice lacking the PTH receptor itself in osteoprogenitors also have severe osteoporosis, and growth retardation is shown on the left. On the right are micro-CT images in the upper panels showing that knockout mice on the right have a significant decrease in trabecular bone, which is the internal, more spongy-looking type of bone, as well as a decrease in the thickness of the surrounding cortical shell shown on the right. In looking at the mechanisms underlying this bone loss in GS conditional knockout mice, we find that there is a significant reduction in the number of mesenchymal progenitors measured by colony-forming unit fibroblast assays shown on the left that are committed to the osteoblast lineage measured by colony-forming unit alkaline phosphatase assays. These mesenchymal progenitors committed to the osteoblast lineage are substantially decreased in the conditional knockout mice. However, if we plate equal numbers of osteoblasts and induce them to undergo osteogenic differentiation, and then assay for the formation of mineralized nodules that are stained red with alizarin red, we were surprised to find that osteoblast differentiation appears to be accelerated in knockout mice. You can see that the red staining appears earlier and to a greater extent in cells harvested from the conditional knockout mice, and shown in quantitation below. In older mice lacking GS-alpha, we show that they have lower bone mass at baseline, and that anabolic PTH, which increases bone mass by approximately 10% in wild-type littermates, has no effect on bone mass in vivo in mice lacking GS-alpha in osteoprogenitors. So confirming that the G-stimulatory pathway downstream of the PTH receptor is an important mediator of the anabolic effects of PTH. But another surprise when we look at the osteoblasts harvested from these mice, again at baseline, the osteoblasts do differentiate more rapidly than control osteoblasts from wild type. But the surprising finding is that when we treat with PTH, which accelerates osteoblast differentiation in control wild-type osteoblasts, it even more rapidly or substantially increases osteoblast differentiation in mice lacking GS-alpha, suggesting that there are pathways downstream of the PTH receptor not mediated by G-stimulatory signaling. And these are an area of active investigation. So our current working model is that mesenchymal progenitors face a decision to become osteoblasts or other lineages such as chondrocytes or adipocyte, and that G-stimulatory signaling downstream of the PTH receptor is important in regulating the commitment towards the osteoblast lineage. However, once committed to this lineage, it appears that GS signaling is important for, in fact, slowing and perhaps controlling the rate of osteoblast differentiation. Another pathway that has been implicated in this commitment of mesenchymal progenitors to the osteoblast lineage is the canonical Wnt signaling pathway. And this is of interest because Sclerostin has been identified as a bone-specific inhibitor of this pathway with relevance to clinical bone mineral density. Sclerostin is a product of the SOST gene, and this gene is mutated in a disease called sclerostosis associated with very high bone mass. Sclerostin binds to LRP5 and 6, which serve as co-receptors along with frizzled for Wnt ligands to stimulate canonical Wnt signaling, resulting in beta-catenin translocation to the nucleus and activation of Wnt target genes. When sclerostin is present, it functions to sequester LRP5 and 6 away from the frizzled co-receptor and thus terminating canonical Wnt signaling. We have been interested in sclerostin because PTH signaling has been identified as a potent inhibitor of sclerostin. Romosozumab is a monoclonal antibody targeting sclerostin, and it's the newest approved anabolic agent for the treatment of osteoporosis. In our mice as they age, we find not only severe osteoporosis, but a dramatic accumulation of adipocytes within the marrow space. Since Wnt signaling is a known regulator of osteoblast versus adipocyte commitment, we've examined Wnt signaling in these mice. And not surprisingly, since PTH is a potent suppressor of sclerostin expression encoded by SOST, we find that in GS-alpha conditional knockout mice, which again cannot respond to PTH signaling, have increased levels of sclerostin. And this is accompanied by decrease in canonical Wnt signaling, represented here by decreased levels of the top gal Wnt signaling reporter. Shown here is our model for how GS-alpha and, by extension, PTH receptor signaling may be influencing the commitment of mesenchymal progenitors to osteoblast versus adipocyte lineages. To the left, you can see that Wnt signaling is an important regulator of this commitment decision. Wnt signaling favors osteoblast commitment and inhibits adipocyte commitment. We have shown that when we delete GS-alpha in osteoprogenitors and subsequent cells in the osteoblast lineage, that there is an increase in sclerostin expression by osteocytes. And we believe that this sclerostin, by inhibiting Wnt signaling, may be contributing to the dramatic increase in fat and decrease in bone mass that we see in mice lacking GS-alpha that are unable to signal in response to the PTH receptor. We're currently working on the mechanisms by which the PTH receptor and Wnt signaling pathways can intersect. On the left, I've shown already that PTH is a known suppressor of sclerostin, which sequesters LRP5 and 6 away from the Wnt and frizzled Wnt receptor. There are some other potential mechanisms by which PTH receptor can intersect with Wnt signaling. As one example, protein kinase A has been shown to directly phosphorylate the Wnt mediator beta-catenin, and we're looking at whether that has also implications for expression of osteoblast gene programs. In the final few minutes, I want to talk about another approach that our lab has been taking in pursuit of a cure for osteoporosis, and that is stem cells as a source of osteoblasts. If we take a step back and think about what we could do if we had an unlimited source of osteoblasts, we could study disease mechanisms in vitro. We could perform high-throughput screening for novel therapeutic compounds. And importantly, we could work on cell-based regenerative therapies for all sorts of orthopedic injuries. For instance, fracture non-union, which affects about 10% of fractures. That is the delayed healing, failure to heal after a fracture. Osteonecrosis, a condition in which parts of the bone can become non-viable. There are various orthopedic injuries that result in critical defects in the bone. And finally, in cancer patients, destruction of bone by tumor. This could be a potential approach for the replacement of that bone. In thinking about potential stem cell-based sources of osteoblasts, there are endogenous mesenchymal stem cells within the bone marrow. There are pluripotent stem cells, both embryonic stem cells and the more recently described induced pluripotent stem cells, first reported by Yamanaka, where expression of 4 factors can induce somatic cells to convert into an induced pluripotent stem cell state. And finally, there's direct reprogramming, bypassing the pluripotent stem cell stage. So we have been interested in both pluripotent stem cells and direct reprogramming. One of the challenges in studying stem cell-based sources of osteoblasts is that unlike hematopoietic stem cells, it's not easy to ablate all bone cells and transplant to replace them. So to get around that, we developed a skeletal complementation assay to take advantage of skeletal genesis during embryonic development. RUNX2 is a master transcription factor for the osteoblast lineage. Shown on the left, mice that are lacking RUNX2 fail to form a mineralized skeleton. So in the blue is staining with Alcium blue for cartilage, and in the red, it's staining for alizarin red for mineralized osteoblasts. And you can see that RUNX2 null mice fail to form, again, mineralized bone. We reason that if we intercrossed 2 RUNX2 heterozygotes and then injected the blastocysts with wild-type pluripotent stem cells, either ES cells or iPS cells, that we would generate chimeric embryos. In chimeric embryos that are derived from wild-type or RUNX2 heterozygous blastocysts, the entire embryo, including the skeleton, should be chimeric. However, in chimeric embryos derived from RUNX2 knockout host blastocysts, again, since they cannot form a skeleton, any bony elements that we find in those resulting mice must be of injected pluripotent stem cell origin. Because RUNX2 null mice lack a skeleton, they cannot survive after birth. And so we harvested these embryos shortly before birth at embryonic 18.5. Shown on the left is a control littermate, wild type, and alizarin red staining showing all the mineralized skeleton formation. Shown on the right is the same skeletal preparation from a RUNX2 null mouse, showing that there is no mineralized bone formation. There are some small regions in the long bones of alizarin red staining that represents mineralization of the hypertrophic chondrocytes in the cartilage, but no bone formation. And in the resulting chimeric embryos, in which the blastocysts have been injected with pluripotent, in this case, embryonic stem cells, we were pleased to see that, in fact, they can contribute to formation of skeletal elements in vivo. So confirming that pluripotent stem cells can contribute to bone formation in an in vivo setting. To determine the percent contribution in the chimeras that's needed for normal skeletal genesis, we took a different approach. We crossed mice expressing Cre recombinase driven by ostrates, again, the transcription factor expressed in osteoprogenitors, crossed to mice expressing an inducible diphtheria toxin such that when diphtheria toxin is expressed, those cells will be ablated. So in mice carrying both the osteoxcree and diphtheria toxin, inducible diphtheria toxin, all of the cells expressing ostrix, that is osteoprogenitors and beyond, should be ablated. We again harvested blastocysts from these mice at embryonic day 3.5, injected them with control wild-type pluripotent stem cells, again generating chimeric embryos. In control animals expressing only the diphtheria toxin without the ostrix-driven Cre recombinase, we would again expect the entire embryo to be chimeric. In mice that express both ostrix-Cre and inducible diphtheria toxin, there should be no host osteoblasts because they have been ablated by expression of diphtheria toxin, and therefore any skeletal elements that we see must be derived from the injected pluripotent stem cells. As a control, showing here a limb from a control mice, you can see the skeletal elements, and in comparison, a mouse in which ostrix-Cre has driven diphtheria toxin ablation of the osteoblast lineage, you don't find any skeletal elements. Because of the expression of GFP in the host, we can quantify the percent contribution from the pluripotent stem cells, which themselves are GFP negative. And so shown here in this panel, the numbers represent the percent contribution from the pluripotent stem cells. And these are images of skeletal preparations. And you can see that somewhere between 37.5 and 50% contribution from pluripotent stem cells, we start to see rescue of apparently normal skeletogenesis in embryonic development. Importantly, we showed that pluripotent stem cells can also rescue the bone marrow hematopoietic niche. So in RUNX2 null animals, shown here in the upper left, the bone marrow cavity fails to form because hematopoiesis is critically dependent upon normal bone-forming osteoblasts. However, in RUNX2 null mice that have been rescued by injection of normal pluripotent stem cells with chimeric contribution of roughly 50%, we find restoration of a bone marrow cavity and hematopoietic elements. And shown on the bottom are both embryonic stem cells and induced pluripotent stem cells, along with the percent contributions below. And you can see that the greater the contribution, the more normal appearing the bone marrow cavity. Now that's important as a proof of principle, but pluripotent stem cells cannot be injected directly in vivo as they can form teratomas. So shown here are pluripotent stem cells differentiating and expressing markers of all three germ lineages. And at the bottom, histology images from teratomas formed in vivo by injection of these pluripotent stem cells, and again with evidence for tissues from all three germ layers. So as an alternative, our next approach was to attempt to differentiate pluripotent stem cells into mature osteoblasts in vitro first, and then to use these as a source for regeneration. To mark the differentiation of mature osteoblasts, we have used a variety of GFP reporters for different stages, ostrix being early osteoprogenitors, type 1 collagen as a marker for maturing osteoblasts, and osteocalcin as a marker of fully mature, terminally differentiated osteoblasts. So we've harvested both embryonic stem cells or fibroblasts from mice with these different GFP reporters. We use the fibroblasts to overexpress the pluripotency factors and generate induced pluripotent stem cells. And then we pursued a variety of protocols to differentiate these ES or IPS cells into osteoblasts using GFP expression as a reporter of osteoblast fate. So our protocol was to isolate, for example, from mice expressing collagen-1 driven GFP, again a marker for maturing osteoblasts. We isolated tail-tip fibroblasts from these mice, differentiated them using embryoid body formation and osteogenic media, and then examined them for the expression of GFP reflecting type 1 collagen and mature osteoblast fate. we can show that they do indeed express GFP and that this GFP expression is localized to mineralized nodule formation, which is where we would expect to find the mature osteoblast. Unfortunately, in looking at the yield, we found that the yield was extremely low, far less than 1%, and this is a very time-consuming protocol requiring several weeks, both to induce pluripotency and then to differentiate into the osteoblast lineage. So again, a protocol that works, but is perhaps not so pragmatic for regenerative purposes. So more recently, we've turned to an approach called direct reprogramming. Shown here on the left is what's referred to as Waddington's epigenetic landscape, showing that committed cells can be induced, for instance, to revert all the way to pluripotency. Those are the approaches I've shown you already. And then those pluripotent cells can be induced to differentiate into other lineages. However, more recently, several groups have shown for a variety of tissues that it is possible to directly interconvert them by the expression of tissue-specific transcription factors. We sought to do a similar approach, again using tail-tip fibroblasts from mice that express GFP driven by type 1 collagen, the 2.3 kb type 1 collagen promoter. We harvested these tail-tip fibroblasts. We infected them with lentiviral vectors containing various pools of osteogenic transcription factors. And then we screened for the expression of GFP driven by type 1 collagen and called these induced osteoblasts. A priori, we set a couple of criteria for proving that these are indeed functional osteoblasts. They should, of course, express type 1 collagen-driven GFP and markers of osteoblasts. They should be able to form mineralized nodules, an assay for osteoblast function in vitro, and those nodules should be GFP positive. Their transcriptome and epigenome should resemble those of native osteoblasts. And finally, and most importantly, they should be able to form bone in vivo. After screening large combinations of various osteogenic transcription factors, we identified four factors, RUNX2, DLX5, Ostrix, and ATF4, which in combination significantly increase expression of type 1 collagen-driven GFP over time. And in these candidate-induced osteoblasts, we can show that markers of osteoblasts, such as type 1 collagen expression itself, or osteocalcin encoded by BGLAP, their expression also increases with time and differentiation. We can show that these candidate-induced osteoblasts do indeed form mineralized nodules, and we can stain for mineralized extracellular matrix using either alizarin red in above or von Casa, staining black below. When we look at these mineralized nodules under fluorescence and stain for the expression of osteocalcin, a marker of mature osteoblasts, we see that osteocalcin co-localizes with GFP driven by type 1 collagen. We have performed transcriptome profiling on these candidate-induced osteoblasts and showed that their transcriptomes much more closely resemble native osteoblasts harvested from Calvaria than they do resemble the parental fibroblast lines. And finally, we show that induced osteoblasts, when implanted in an ectopic bone formation assay, can form mineralized bone, whereas the parental fibroblast cell lines cannot. And that under histology, these bony elements do stain positively for mineral with alizarin and von Casa, that they express GFP, and that this GFP co-localizes with osteocalcin, a marker of mature osteoblasts. So with that, today I've discussed that osteoporosis is a very common disease of skeletal fragility, that the risk of fragility fractures rises sharply with age. We will need, in order to cure osteoporosis, methods that can elicit safe and sustained bone formation. Are currently available anabolic therapies that increase bone formation, target PTH receptor and Wnt signaling pathways, and the molecular mechanisms underlying these are in active area of investigation in my lab. And we've also been very interested in stem cell-based sources of osteoblasts that hold promise for skeletal regenerative medicine. With that, I want to thank the members of my lab who have done much of this work, my sources of funding, and all of you for your attention. And I look forward to answering your questions. Thank you.
All right. Thanks so much for that presentation, Joy. And we've got lots of questions here, which is really great. Just as a reminder, if you do have a question for Joy, please use the Ask a Question panel to submit that question, and we will try to get to it today. All right, Joy, are you excited to answer some questions?
I sure am, Sarah. I love talking about bones.
Okay, great. All right, so our first question here is it true that lactation is a long-term protective factor for osteoporosis?
So in the short term, women who undergo pregnancy and lactation lose a significant amount of bone mass. All of the calcium in the fetal skeleton comes from the mother. And so there can be a decline of 10% or more of the bone mineral density in the months after pregnancy and lactation. However, unlike menopause, the bone loss during pregnancy and lactation is fully reversible. In the long term, I'm not aware of strong data that link lactation and or say the number of pregnancies to osteoporosis risk.
Okay. We've got another question here. This question is, what flavanols have been tested for senolytic treatments?
That's a great question. I'm familiar with the published data on quercetin, which was part of the dasatinib and quercetin trials in the rodent studies that I showed. I imagine that flavanols are being broadly investigated for their role here, but it's not my particular area of focus, so I'm not able to answer that in more detail.
Okay. Our next question here is, given the focus on aging, can you comment on human age-related differences in parathyroid hormone signaling and Wnt signaling?
That's an interesting question. So whether the responses to these signaling pathways differ. So my understanding is that the anabolic responses to PTH still occur with age, but I don't know in molecular detail whether the pathways downstream sort of become blunted, but that's an interesting area of investigation.
Mm-hmm, definitely. Another question here is, age-related bone formation tracks with sarcopenia. What will happen if only bone mass increases using the technology you're studying?
Well, this is a fascinating area of research, the crosstalk between muscle and bone, and especially myokines that may be signaling. So I think that in vivo, of course, bone and muscle are sort of working closely together. So I think it will be important to study the effects, but my sense is that there will be some crosstalk between the organs, and it's unlikely that you would have effect only on one without the other.
Mm-hmm. Awesome. We've got a comment and a question here. The comment is great presentation. The question is, have you or are you planning to inject the inducible osteoblasts into a disease model for osteoporosis or osteopenia?
That's a great question. So the challenge with osteoporosis and osteopenia, of course, is that you have humans on average 206 individual bones. And so I'm not sure that injection of induced osteoblasts will necessarily be a route to cure for osteoporosis. I do think they will be a valuable model for screening, for instance, high throughput drug libraries, maybe to identify new pathways to target. However, for localized skeletal destruction, some of the examples I gave were fracture non-union or tumor-mediated destruction. I do think that cellular-based regenerative therapies could be very promising.
Mm-hmm. Great. Okay, another question here is, why not limit the natural OSKM limiting pathway rather than overexpressing it?
So I think you're referring to the induced pluripotent stem cell protocol overexpressing the OSKM factors. So I'm not aware of a single pathway that is responsible for downregulating the pluripotency factors during embryonic development. And in these protocols, the pluripotency factors are usually transiently overexpressed. But it's an interesting idea of targeting the inhibitors rather than overexpressing.
Mm-hmm. A cool approach, definitely. The next question is, have you tried examining the bone phenotype and the response to PTH in GS knockout mice using the COL1 Cre promoter or inducible Cre?
Right, another great question. So the collagen 1 driven Cre recombinase would target osteoblasts at a later stage of maturation than we have using the ostrix driven recombinase, Cre recombinase. We have not used those mice. I know that many years ago, Lee Weinstein and his group at NIH generated collagen 1 Cre driven GS alpha conditional knockout mice, but I am not aware of whether he has treated those mice with PTH to examine their response.
Okay, definitely something to look into. Another comment and question. The comment is brilliant presentation. The question is, do you think that exercise training may promote similar benefits for bones as the drugs that you mentioned?
Exercise training is very important for bone health. I counsel all of my patients on the importance of exercise regularly, and in addition, the benefits of dedicated weight and strength training. I think for many years, we have clinically been quite cautious about advising weight-bearing studies, especially in older patients, out of concern for injury and or even fracture. However, there's a very interesting set of studies called the Liftmore study, in which women around the age, I think the mean age is about 65, were actually subjected to pretty rigorous weight training regimens and demonstrated quite a substantial improvement in bone mineral density. So I think that's a very promising area of further study. And I do think that exercise can be very beneficial for bone health.
Mm-hmm. Great. Next question here is, are studies transferring pluripotent cells in aged animals?
Are studies transferring pluripotent stem cells in aged animals? So we have not so far looked at their function in age, but I do think that that is one of the hopes, is that the lessons that we learn from using these various pluripotent stem cell-based protocols will be applicable to aging-related degeneration in the skeleton.
Mm-hmm. Great. Okay, we've got a couple more questions here. I know we're running out of time, but that's okay. If you do have questions for Joy, just another reminder, please submit them using that Q&A panel just to the right of the slide viewer. Okay, so this question is there any known adverse effects of using PTH in long-term or short-term basis? Since PTH is bone anabolic, does it intensify vascular calcification or like ectopic bone formation?
Right, great question. And we don't really know the, the answer to that. In preclinical rodent studies, both, teriparatide and abaloparatide were associated with an increased risk of osteosarcoma in rodents. And for that reason, both carried for many years a boxed warning on the label from the FDA, limiting lifetime use to 2 years. Now, teriparatide, which is marketed in the US as Forteo, has been on the market for more than 15 years, and there's no hint that there's an increase in the risk of osteosarcoma in people. And so the FDA has recently released that box warning from teriparatide, but not yet from abaloparatide. So we simply don't have long-term data. There are patients who have hypoparathyroidism who are treated with a slightly different recombinant form of parathyroid hormone for many years. So I think eventually we'll have understanding from that group of patients.
Mm-hmm. Great. Another question here. If you focus on improving systemic inflammation or redox balance, do you restore dysregulated endocrine signaling to bone?
So that is an area, I think, of very high interest in skeletal aging field. It's quite clear that inflammation increases with age, and that inflammation can contribute to bone loss, both with aging and in various inflammatory conditions, for instance, rheumatoid arthritis. So there's a lot of interest in how we might be able to target inflammation, but it's difficult. It's a systemic process, but it certainly plays a role in aging-related bone degeneration.
Okay, great, makes sense. Another question here. Is the mortality following hip fracture different for men and women?
So about a quarter of hip fractures do occur in men, and the mortality rate does appear to be higher. Overall, it's thought to be about a 1-year mortality rate of 20%. And I've seen studies that have quoted numbers as high as 30% for men. Now, some of that is because men are on average older when they fracture. They start with a higher bone mass at peak bone mass. And so they're often on average about a decade older than women. So there may be other issues contributing to frailty that account for that increased mortality for men.
Okay, that makes a lot of sense. And I think just based on time, we're going to make this our last question. Okay. So this question is, how can we explain the fracture? How can we explain that the fracture of the hip decreases after 75? Is this because of reduced activity?
So I think you're referring to the introductory slides I showed about the distribution of fracture types by age. So yes. Some of that could be related to decreased activity with age, but I think it's more likely just that many clinical trials tend to enroll individuals up until the age of 70 to 80. And so the data is not collected at the same rate in older populations. So I think we just don't have the numbers for individuals over the age of 80 or 85. And that probably accounts for some of that apparent drop off on those figures.